A clinical approach to the diagnosis of Kawasaki disease in cases of fever of unknown origin. Kawasaki disease (KD) is an acute systemic vasculitis, the diagnosis of which is established primarily based on clinical criteria, including prolonged fever, rash, conjunctivitis, changes in the oral mucosa, changes in the extremities, and lymphadenopathy. However, these criteria have limited sensitivity and specificity, especially in cases of incomplete or atypical presentation. When conducting clinical screening for fever of unknown origin, the possibility of CHD should be considered when pyrexia persists for more than 5 days and is accompanied by signs of inflammation, as delayed diagnosis increases the risk of coronary artery abnormalities and cardiac complications. Laboratory markers, such as elevated levels of pro-inflammatory cytokines IL-6, IL-10, IFN-γ, have been identified as potential biomarkers for identifying severe forms of the disease, particularly Kawasaki disease shock syndrome, which facilitates early diagnosis and risk stratification. Novel diagnostic tools, including colorimetric sensor arrays for urine analysis and corresponding algorithms, show promise in differentiating KD from other febrile illnesses, supporting clinical decision-making with high accuracy in borderline cases. Concomitant infections, such as respiratory viruses, can alter the clinical presentation of HF and the response to treatment, underscoring the need for comprehensive screening in children with fever. In newborns and in cases of atypical presentation without fever, vigilance regarding CHS stigmata such as rash, desquamation of the skin of the extremities, and lymphadenopathy is critical, and echocardiography should be performed immediately to detect coronary artery involvement.